Wake up. It's the Sleep Unplugged podcast, episode 110, the sleep apnea pill, wired on the pills you took. Welcome, everyone, to the Sleep Unplugged podcast. My name is Chris Winter. I'm a neurologist and sleep specialist and your host for this episode of the podcast. If you're new to the Sleep Unplugged podcast, welcome. If you're a veteran of our podcast, welcome back. Excited that you're here. We have had a busy week here at the Sleep Unplugged podcast. We have eclipsed 175,000 downloads since we started, well on our way to 200,000. And it's really, really exciting. So really appreciate everything that you all have done to make this podcast fun. We have our comments, corrections, criticisms as we get into the podcast. I wanted to read two comments. These were reviews of the podcast left by listeners. The first is from Sue's Q's, and she wrote, you don't have to have a sleep disorder to be hooked. I'm glad I accidentally came across this show by searching narcolepsy. I can't wait to share with my sleep doctor so he can step up his game. I'm assuming you're talking about Dr. Chris, the other sleep doctor, Chris, that shares my name, because I think that guy needs to step up his game. And if you're listening, Dr. Chris, tell me I'm wrong. Just kidding, Dr. Chris. Dr. Chris is awesome. You can follow him. And we've talked about having a little competition to find out who is the best Dr. Chris. And we'll get back to that soon enough. Chris is so down to earth and freaking funny. He truly enjoys helping us all with practical and interesting content. I love that he is schooling us on music that he loves and incorporates it in the title. He makes learning fun. I'm clearly obsessed. My husband might be getting concerned since I may be losing sleep right now trying to binge listen to all the episodes. Can't get enough. Dr. Winter is legit my new celebrity crush. Love him. So I'm assuming that is my wife or potentially some other friend of mine who put that. I'm kidding. Sue's Q's, thank you very much. Really appreciate it. There was another review that I wanted to listen, slightly less positive or exciting, but wonderful nonetheless. This is from Go Who's 98. I love that. Hey, Dr. Winter, I've really enjoyed listening to your podcast on all things sleep. After I was diagnosed with sleep apnea and PLMD by you, I have yet to find a doctor in New York City who takes the time to understand the individual plight of the patient like you do. Give me a call because I got a bunch of them. I've listened to a lot of things related to sleep, but largely PLMD, as it is a bit harder to treat than OSA. I agree with that. But there's a great book coming out by a good buddy on restless leg and PLMD that we'll talk about soon. This is from Dr. Spector. So look that up on Amazon. I think it comes out in September. Treatment. I imagine there are many people who have an inking that sleep may be the cause of some of their symptoms, but are unsure where to start. It seems to be one of those more common sleep disorders, but often may not cause daytime symptoms. It caused me about 22 arousals per hour for me. I'm sure there are others who are deeply affected by it. That's enough for me. Again, thanks for being a great doctor and for the content you put out there. Go Who's 98. So clearly we share an alma mater, and I appreciate you taking the time to put that on there. I did this originally for my patients. I really never thought anybody outside of my clinical practice would listen to it. So it's always really exciting that people are out there listening. So if you listened to last week's podcast on sleep in the elderly, that was that one was a very successful episode. We put a little quiz on there, and I said I would send out a prize to anyone who got the answer to this question right. And our listener Bruce, who spells his name, I've seen people spell their name if they have an S with the dollar sign, which I like. That's great. CHRI dollar sign is maybe a way I could spell my name. Bruce spells his name with the C as the sense mark because Bruce has a lot of music sense, I guess, because he correctly identified episode 13, You Gotta Move, was the song You Gotta Move from the Rolling Stones album Sticky Fingers. Number 29, Out of Our Heads. And number 32, Let's Spend the Night Together, which Bruce actually wrote, was also covered by your fave, David Bowie. And he's exactly right. So those were the three Rolling Stones music references we made. And then last week, I had to put What a Drag It Is Getting Old off of Mother's Little Helper for many obvious reasons if you listen to that. So, Bruce, with the cent sign, you will be getting a Sleep Unplugged trucker hat in the mail. We'll just have to get that arranged. Thank you for playing. A couple of you made valiant efforts. Bruce was actually the only person who got it right. So great for you. This week, the music lyric was Wired on the Pills You Took, was from one of my favorite groups, The Cult. And this was from the song Edie Chow Baby off their fourth album, from 1989, Sonic Temple. And I remember a guy in my dorm room at UVA, Go Who's, had the Sonic Temple poster on his wall, and it was awesome. It was Billy Duffy in full, rock god mode with his guitar. He was the guitarist for The Cult. And then Ian Astbury, hair going all over the place, singing in the background. One of the most distinctive voices in the world. And speaking of distinctive voices, anybody who listens to this podcast know that we are big Celine Dion fans. She's one of the few special invited guests who has an open invitation to be on the show at any time. Wow, what a performance. What a comeback for the opening games of the Paris Olympics. Just had to give a shout out to Celine Dion, who I am still upset because Rolling Stone named the top 200 voices in music of all time, and she's not on the list. Do I own a lot of Celine Dion albums? No, but by God, I can recognize a good voice when I hear one, and she's a great voice. Congratulations. It's so great, awesome to see you back. So back to The Cult, Ian Astbury, Billy Duffy, and many revolving musicians over the years. One of my favorite groups, Rain, their second album was huge. She Sells Sanctuary is one of the songs that remain on just about every one of my exercise gym playlists. It never leaves. They followed up Rain with Electric, which Wildflower, big song off that album. That was an album actually produced by Rick Rubin. And then their fourth album, Sonic Temple, was a very divisive album. I thought it was a great album, had really good songs. Edie Chow Baby, Firewoman. Edie Chow Baby was about Edie Sedgwick, the model, part of Andy Warhol's factory. The title of the song, Edie Chow Baby, her final movie before she died was Chow Manhattan. One of my favorite lines talks about her being a youth Quaker. And that's from actually Vogue magazine in the mid 60s named her youth Quaker. That was a word they used because of the cultural significance that she had. I always thought that was an awesome word. So it was a very, very cool song. Died at a very young age of addiction and drug overdose, I believe. Very sad, but great song that we'll put on there. I almost went with Pills and Thrills and Belly Aches, which was the album from the Happy Mondays that Step On was on. So we might have to put Edie Chow Baby in The Cult. Might have to throw Step On onto our Spotify music playlist. So all the music we talk about on the show is on the Spotify music playlist. We are now on volume 3. So if you just search up Sleep Unplugged, volume 1, volume 2, volume 3, you can see all the music we've talked about on the show. So as I talked about in last week's episode, this is an episode I've wanted to do for a while. With the big Biden announcement last week, I thought this is a good time to talk about sleep in the elderly, but I wanted to circle back to this topic because I've had several people write into the show, hey, can you talk about other treatments related to sleep apnea besides CPAP, which we've talked about in a couple episodes, I believe, surgery, and oral appliances? And surgery gets a lot of interest and attention. The commercials for the Inspire Why wear a CPAP mask when you don't have to? We talked about the Inspire devices. This thing gets implanted in your neck, and it's right for the right kind of person. I think that there are a lot of things missing from the commercials on Inspire, namely the fact that we're going to open up your neck and put a device in there. Oh, and also a little controller in your chest as well too. So again, not a huge surgery, but it is surgery. This is not a laser surgery for a skin blemish or something. This is an open suture you up kind of surgery. And so a lot of people have expressed interest. What about medicine for sleep apnea? In fact, there have been two listeners, both named Bill, who've written in, one from Texas, one from Massachusetts, who said, can you do an episode on the sleep apnea pill, whatever that means? And I think once you get two listeners with the same name asking the same question, I think there is a law that says you have to do that episode. So here we are. There have been attempts and investigations of many medications prior to the medication we're going to talk about today as a treatment for um, sleep apnea. And without fail, most of these medications have not been particularly useful. Diamox is a medication that was looked at that showed a very, very small signal in terms of improving mild apnea in a study a long time ago. That's the only medication that I'm aware of that's ever really shown anything up until recently. And we're going to talk about one medication, or it's a combination drug specifically. There is another medication I couldn't find a lot of information about. IHL 42X is another drug that's actively being investigated as a treatment for sleep apnea. This is a drug that contains dronabinol, which is a drug that's often used for chemo-induced nausea and other synthetic cannabinoids. And we did an episode on marijuana and cannabinoids a while back. And these drugs, as they become the restrictions have been taken off of them, you're going to see a lot more investigations of these medications. Currently, there's no guidelines for using those to treat sleep apnea, to be clear. So in December, so several years ago, the company, I think it was in 2021, with the first investigations, I believe, being in 2022, there was a combination of two medications that showed some promise in terms of treating sleep apnea. And this combination drug, if you want to look it up, is AD109. And it's a combination of a drug, eroxybutynin, and many people may be familiar with oxybutynin, ditropan, which is a drug that's often used to treat overactive bladder. So it's a combination of that drug as well as the drug Strattera, which the drug name for Strattera is um, an amoxamine. Uh, and that drug has been used for attention deficit disorder, as well as some other, cognitive thing. I think the ADHD is the only official FDA approval that it has. So combining this drug, these two drugs together, they're actually actively investigating this as a treatment for sleep apnea. So just really quickly, when you think about the types of drugs these are, eroxybutynin is an anticholinergic drug. So when you think about that, what I want you to think about is acetylcholine is a neurotransmitter. And we talk about a lot of neurotransmitters on this show: dopamine, norepinephrine, serotonin, hypocretin for when we're talking about narcolepsy. And so oxybutynin is a anticholinergic drug. So it is being used to reduce the amount of cholinergic tone when you take it. And I remember learning in medical school when you take too much anticholinergic, red as a beet, dry as a bone, mad as a hatter. So that's sort of the triad of anticholinergic toxicity when you take too much of it. So the dry as a bone is the effect here. We don't want you to be too dry, but it's helping to, slow down an individual's urge to urinate. It's also sometimes used off label for people who sweat too much, or even in bedwetting in some people. So that's the oxybutynin, the anticholinergic portion of the drug. In terms of the atomoxetine, or Strattera, as you might know it by, this is a drug that has nothing to do with acetylcholine. It's noradrenergic. So instead of norepinephrine, we're trying to enhance that. So there are drugs that we use in sleep already that have pro norepinephrine properties. One of them being Sunosi, which is a drug for narcolepsy. It is a drug that increases dopamine and norepinephrine together. So it's a dopamine and norepinephrine reuptake inhibitor. Strattera is just a norepinephrine reuptake inhibitor. And just as a disclosure, I do some work for the drug company that makes that markets Sunosi. Just putting that out there. Um, uh, so so moving forward, this drug has really taken off. And if you look up the company Apnimed, Apnimed, this company is all in on this drug. I mean, I just was kind of perusing the website recently, like who are we? I expected like three, whenever you look up who are we for the new fitness monitor or the new sleep tech thing they've got. It's like, these three people and somebody who's answering the phones. This is not what's going on at Apnimed. This is a massive operation in terms of promoting and pushing this drug forward. And so there's studies about this drug, and the one that I will talk to you the most about was from this past December 2023, and you can look it up. The study was called "The Combination of Oxybutynin and Atomoxetine in the Treatment of Obstructive Sleep Apnea Syndrome: A Randomized Control Trial." So they're after it here. They're after the holy grail. And let me tell you something. I think it's important for when you listen to this episode that it pairs nicely. It pairs nicely with an earlier sleep episode we did, episode 5, mild sleep apnea, death by CPAP. Now I'm going to give you the quick Cliff Notes version of mild sleep apnea, death by CPAP. Sleep apnea is a condition that affects a lot of people. It is a condition that affects the health of a lot of people. It is a underdiagnosed disorder, meaning there are a lot of people out there who have it, and fixing it can radically change people's health. All of those things are true. I think the thing that I want you to have in your mind about sleep apnea, I want you to think of the word spectrum. And what I mean by that is, hey, Chris, how is a person diagnosed with sleep apnea? And I would say, that's easy, listener. You just have to have 5 breathing disturbances of significance or more per hour. That's it. So if you stop breathing for more than 10 seconds and your oxygen drops by 3 or 4%, depending on the criteria you're talking about, I think in this study it was the 4% criteria, you have sleep apnea. So that begs a secondary question, which is, what's the worst sleep apnea that you've ever seen? Worst sleep apnea I've ever seen, 155.6 breathing problems per hour. So you said 5 was considered sleep apnea. So when I ask somebody, do you have sleep apnea? And they say yes, that person could have 5 breathing problems per hour. They could have 155.6 breathing problems per hour. They theoretically could have as many as 180 breathing problems per hour, but that would be a very difficult number to hit for reasons that are academic and not really worth getting into. So keep that in mind. I also want you to keep in mind the idea that we categorize sleep apnea commonly based upon severity. And one might think, okay, well, your span's about 150, it seems like. So what, 0 to 50 is mild, 50 to 100 is moderate, 100 to 150 is severe, right? No, not even close. It's 0 to 5 is normal, 6 to 20 is mild, 21 to 30 or 35 is moderate, anything above 30, 36 is severe. That's the current criteria for severity. And there's a variety of reasons for it. I don't agree with them. I think it's misleading and difficult. And it also creates confusion. So you're going to call the person who has 36 breathing problems per hour severe. You're also going to call the person who has 136 breathing problems per hour severe. Okay, that makes sense. So anyway, so I want you to have that in mind. Let's write on the dry erase board that we have in our office, 0 on this side and 155 over here, and you can kind of categorize stuff as you like. And that's important as we start to dive into what this study is telling us, because this study does a lot of things. It starts off by talking about how prevalent disorder is, how difficult it is to treat. People don't like wearing CPAPs, and it's important that we treat it because there's medical consequences if we don't. There we go. So when you look at the headlines of this study, the AHI, how many breathing problems they were having per hour, was reduced by 45% of people, by 45% in the people taking this experimental drug, the AD-109, compared with placebo. Wow, 45%. 44% of participants who received this experimental drug had a greater than 50% reduction in their AHI. Wow. I mean, what else needs to be said? We can sign off on this podcast right now. We've done it. We've cured sleep apnea, right? Not so fast. Everybody knows who listens to this podcast knows I hate percentages. I hate percentages, especially when you're not tying them to real numbers, because you could have 2 breathing problems per hour, work some magic, and now have 1 breathing problem per hour. You just reduced your AHI by 50%. Is that meaningful at all? No, it's not meaningful whatsoever. I don't think anybody would argue that it is. It's still a 50% reduction. So I really want to dive into the numbers, because understanding how the study was set up and understanding the numbers is extremely important. So in this study, there were about 211 subjects, of which 181 qualified to be in the study. It's important to understand that those numbers are relatively small. For sleep apnea, that's a relatively small group. When you're looking at trying to figure out the powers of these studies, they were appropriately powered, but still quite small. You're also looking at a group whose AHI started out in the study. When you came into the study, your average AHI was about 20. So you came into the study with essentially mild apnea. So that's really important too, because if you go back to episode 5, I made a joke, and the joke was the hardest patients to treat in a sleep clinic are those individuals who have mild sleep apnea. And we see them quite a bit. Why? Because you've got mild sleep apnea. It's like having mild vision problems. You have 20/40 vision. How excited are you going to be by going from 20/40 vision to 20/30 vision? That's a pretty significant increase. You're halfway to 20/20 now, but you started off at 20/40. You probably didn't even notice you had a vision problem unless you were looking at a sign on the other side of a stadium kind of thing. So let's dive into what this study showed. So there are actually 4 arms in the study. The first was the AD-109 formulation, where you had 2.5 milligrams of the R-oxybutynin, 75 milligrams of the atomoxetine. In the second group, you had a slightly higher amount of the oxybutynin, 5 milligrams, same amount of the atomoxetine. In the third group, just atomoxetine. In the fourth group, placebo. Okay. So we're starting off at about 20. So in the lower R-oxybutynin group, you went from an AHI of 20.5 to 10.8. You went from mild sleep apnea to mild sleep apnea, right? 6 to 20, we consider mild sleep apnea. So, okay. In the slightly higher R-oxybutynin group, you went from 19.4 to 9.5. So I guess mild sleep apnea once again to mild sleep apnea. In the atomoxetine group, all by itself, 19 to 11.8. So, in broadest of strokes here, you've gone from 20 to 10, 20 to 10, 20 to 10, essentially, really 2011, 2012, whatever. So, placebo group went from 20 to 16. So, whenever you look at a study, what I like to do personally is forget the 20. Let's look at the maybe the best one here, the 19.4 to the 9.5, or the 20.5 to the 10.8. Okay, you 20.5 to 10.8, you improve 10, a little bit less, but 10. What did you improve in the placebo? About 4. So what's the difference between 10 and 4? 6. Talking about 6 points here. What is the error of if you put somebody through a sleep study, 10 nights, what does that data range look like? I mean, these people are not going to have the exact same AHI every night. When they're on their back, when they're on their side, kind of stuffed up one night, had a drink before you came to the sleep center. I mean, there's a lot of variables there that change that. So what is the typical spread of the same person who has a sleep study done 7 nights in a row? I'd be shocked if it wasn't around 6 points one way or the other. So this was statistically deemed significant. So I'm going to assume that it was, that this was not chance. This is outperforming the placebo by 6 points in a group of mild sleep apnea patients. And then they kind of go on to talk about, this is big news and this is great. It's shocking to me within the discussion that there wasn't sort of a real world look. 6 points is relatively meaningless. And what's really interesting was when you ask patients how did they feel on it, it really didn't separate particularly well from placebo. That was one of the biggest criticisms about this. And I'm going to tell you this, the CPAP probably wouldn't either in a lot of cases. That's what we were talking about in episode 5. You've been diagnosed with sleep apnea. You've been told you need to wear a CPAP. But wait a minute, you ask because you listen to this podcast, what is my AHI? And the sleep doctor that diagnoses you says 12. Is it wrong to treat that sleep apnea? Absolutely not. Absolutely not. If that's your choice, you can absolutely do it. Have I seen patients with mild apnea treat their apnea with a CPAP and it changed their life? Yeah, I've seen it. Do I see it a lot? No. Do I see people who treat their mild apnea? They wear the CPAP. They are perfectly compliant with that therapy. And they come back and say, Chris, I don't see any difference whatsoever in terms of the way I sleep or feel. In fact, I might even feel a little bit worse. Yes, I see that all the time. Is there debate within our community about whether or not we should be aggressively even treating mild sleep apnea? So if I have 4 breathing problems per hour, I'm fine. But if I have 6, I need to wear a CPAP the rest of my life because somebody decided that 5 would be a good number to make. When I was first in sleep, 0 to 15 was considered normal. Just think about that for a minute. And I'm not so sure that We need to really be treating aggressively the people with 5, 6, 7 breathing problems per hour. So to me, let's take this number 6 over placebo and let's triple it. 18-point improvement. Now, give me a sleep apnea patient who's got an AHI of 78. You telling me that there's meaning in terms of this drug when they're going to go from a 78 to a 60? I don't think so. So, and when you start looking at surgical corrections for sleep apnea, CPAP corrections for sleep apnea, and 6 points doesn't even get you out of the starting blocks here. So, what are some potential problems here with this medication? Well, number one is side effects. Now, don't get me wrong. A lot of people don't care for CPAPs. And I'll be very clear to the CPAP community. I love CPAPs. I have no vested interest in them. I don't own any kind of CPAP company. When you get a CPAP and use a CPAP, I don't get any money in return for that. I just get the satisfaction that you're sleeping better and feeling better and less likely to have a heart attack and a stroke and have blood pressure and diabetes and gain weight and have depression and yada, 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 all the great things that go along with wearing a CPAP. But it's not an easy thing to do. And it's not something that a lot of people are excited about. So again, I'm not criticizing CPAP. I got a real angry email one time when I did that mild sleep apnea episode from the sleep apnea community. So the side effects from this medication, most commonly dry mouth, interestingly, because that's probably the most common side effect of a CPAP. And the dry mouth is most likely coming from the oxybutynin. That's, again, dry as a bone. We're drying things out, but we're also drying people's mouth out. Number two, insomnia. I'll tell you a story. There are a lot of people with insomnia. And if you have insomnia, I know it's not Insomnia Monday, but I want you to listen because this is a very common thing that I see in my practice. You've got insomnia. You struggle to sleep. It takes you 4 hours to fall asleep. You're on 3 different sleeping pills, and you're at your wit's end. And somebody convinces you to go see an individual who has sleep specialist, MD, or whatever on their sign. And you go, and something happens, and all of a sudden, you're having a sleep study, which I don't think is really the right call for the majority of people who have insomnia. I don't think you need a sleep study right away. But this pathway that I often see is you're having insomnia, you see the sleep specialist, you go right to the sleep study, and guess what? Because that bar of sleep apnea diagnosis is pretty low, you get diagnosed with sleep apnea because you're an adult and lots of adults have mild sleep apnea. You've got an AHI of 12. So where are you headed now? You guessed it, to a CPAP. Now, why did you come in the first place? Because you couldn't sleep. Now we've put a leaf blower on your face. And again, not making fun of the CPAP, but that's what it is. It is a blower. It is an airway splint that uses air to force air. And now you're wearing that because that's going to help you get off of the 3 medications you're taking to fall. No, no, it's the bait and switch. So the insomnia is a meaningful side effect in this population because a lot of people who come to the sleep clinic are not successful sleepers. So we have to be very careful with that. The other criticism with this pill is that there really isn't that kind of change in baseline. We've talked about the Epworth from the sleep apnea group to the treatment group. So you went from 20.5 breathing problems per hour to 10.8, but your Epworth really didn't change, right? Because your AHI's barely changed, right? I mean, why do people wear a CPAP? Do you want to know why? Because they feel a lot better. God, you better believe they feel a lot better. You'd have to feel a lot. I'm going to commit to wearing this thing on my face for the rest of my life. Of course, you need to feel better. And people do. I mean, people name their CPAPs. People go to hotels when the power goes out because they refuse to sleep without it. People love their CPAPs. Chris, I don't like it, but I love what it does for me. I'm not sure people in this study were loving what this combination drug did for them. It moved the needle statistically 6 points. You're going from an AHI of 20 to an AHI of 10. You know what's funny is in the clinic, I would have the same conversation with those people. Here, I'll give you another insight about that. We used to do this a lot more before the advent of the auto CPAP. You would go in for a sleep study. We know you have sleep apnea. They put a CPAP on you, and now the tech starts running the show. And back in the day, you would start off at a pressure of 4. Yeah, they're still having breathing disturbances. So after a period of time, they'd raise the pressure because what they're trying to figure out is what continuous positive airway pressure is required to make your breathing disturbances normal. 5 breathing problems or less. You know, when I look at CPAP data in my clinic, I'll look at it tomorrow. Somebody will come back, it's been on CPAP for a year. They're going to have an AHI of 0.8, 1.2 as registered by their CPAP, under 5. If you're a patient with mild apnea and you're doing a titration and you've got an AHI of 20, your pressures are going to go up. The tech's going to turn them up. Okay, we put you up to a pressure of 9. Pressures are still 10.8. They're going to keep going. So the result from this study, if you saw that during a titration, that tech would keep going on the pressure. She would not consider things complete. So the third thing I'll mention about this was cardiovascular safety, blood pressure and heart rate increases. And you could make the argument that you've got it either way, untreated sleep apnea or treated with a pill that might increase pulse and heart rate based upon what you imagine a drug like Strattera might do. So there's a little bit of confusion there in terms of what is this overall cardiovascular risk in patients who were trying to reduce cardiovascular risk. So, I don't mean to stamp out the fire here. I mean, it's great that we're trying to find this pill. But Bill, I think we've got a lot of work to do ahead of ourselves. And it's going to be very interesting to see if this pill ever comes to market. Because once again, you could say sleep apnea is serious, true. Affects a lot of people, true. Wearing a CPAP can be difficult, true. This medication statistically improves patients who have sleep apnea, true, but is it meaningfully true? And meaningfully true is what we're looking for on the Sleep Unplugged podcast. So that's it. Sleep Unplugged or sleep apnea pill done and dusted. If you have any questions or concerns, comments, corrections, criticisms, you think this pill is going to revolutionize sleep, I want to hear about it. Tell me I'm wrong. Thank you very much for our listeners who take the time to leave reviews of the podcast. Appreciate Bill. Bruce will get the hat out to you. Until you can find me on my social media, Dr. Chris Winter Instagram, Dr. Chris Winter Twitter. We have a YouTube page with all of our videos. Look up the Spotify playlist. And until next week, sleep well.